Yes, my beautiful friends and family, and today we are here. Started yesterday on arthritis. Sorry, we started yesterday on arthritis, and we have done several types of arthritis, and arthritis that you've seen us work on are rheumatoid arthritis. We have done infectious arthritis and gout arthritis. Those are the arthritis that we have worked on. Arthritis. Arthritis is an inflammatory response. Your body responding to some factors in your system. And now, today, I've characterized this topic into several uh, types of arthritis. Like we have characterized them in several types so that people could understand. You see, like we did osteoarthritis, which is degenerative wear and tear arthritis, and I drew some figures, some objects, not objects. I drew some diagrams, and we talked about this one. See this one, pelvic girdle. The pelvic girdle. Let me get something I can. Yeah. Yes, I'm back. I'm fixing 1, 2, 3 things here before we continue on our topics that are here very important. I'm looking for my diagrams. A diagram so that it can be easy to see a diagram. Below the knee, above the knee. Yes, welcome again. Sorry for the problem that has just occurred. We continue on our topic. Our topic was I was saying we are talking. We will try and work out the topic on arthritis according to how the pathophysiology is, according to how the issue is coming out. Now, we said we started with the degenerative arthritis, whereby it's a type of, hello Marcia, welcome. I'm categorizing at this thing called arthritis. Now, let me put this one here so that when I am talking, at least I I'm writing something. Put this here. This one here. Yeah. We're gonna talk about several types of arthritis, and I'm going to write them down. I'm going to write them down so that we understand. We have arthritis called degenerative. Degenerative. Under degenerative arthritis, under degenerative, we have something called, push this here so that you can view it well. Now, under the degenerative, we have osteoarthritis. Osteoarthritis. But there are other type of arthritis that we have that are called inflammatory arthritis. We have inflammatory. We have inflammatory arthritis. Now, inflammatory arthritis, that is where we get rheumatic arthritis. So when I write RA, you know that is rheumatic. Rheumatic arthritis. We have rheumatic arthritis. We have ankylosing spondylitis. Ankylosing spondylitis. Ankylosing spondylitis. This one, AS. Ankylosing. This one affects the back so much. Those people that have back problems. And then we have juvenile for kids. Juvenile arthritis for kids. And then we have reactive. Arthritis. So we have done two under this. Welcome, Doreen Small. We are now categorizing arthritis. Now we have done two of the arthritis. The arthritis that we have done here under inflammatory arthritis, one is rheumatic arthritis, and two, reactive. Reactive is where you have an infection and then the infection comes out and it starts to be a problem. You see, we push this one here close so that people may see. Yes, like that. You see, when we have reactive arthritis, we are talking about an infection that brings arthritis. So today I've categorized degenerative arthritis. We have only one, osteoarthritis, and it is degenerative because it wears off the bones. And you remember our talk about osteoarthritis. And then we have another form of arthritis, which is called inflammatory. Inflammation. You remember inflammation. Inflammation comes with redness, swelling, heat when you are. So if you go back to the start, we talked about how inflammation can occur and how inflammation can make someone to have problems. So inflammatory arthritis, we have talked about rheumatic arthritis. Ankylosing, we have not talked about. Juvenile, we have not talked about. Reactive, we talked about infection. So today we are starting with psoriatic arthritis. So what do we know about psoriatic arthritis? Psoriatic. Anytime you hear something called psoriasis, anytime you hear something called psoriasis, what do you know? Do you think psoriasis is? Psoriasis, anytime you hear about psoriasis, you think about the skin. Anytime you think about psoriasis, always be thinking about the skin. Psoriasis means the skin peeling off. You see, this is a form of arthritis. Listen, psoriasis means the skin peeling off, a form of arthritis. So, how do we know that this is a form of arthritis? Psoriasis is a chronic inflammatory autoimmune arthritis that occurs in some people with psoriasis, skin problems. So you can have arthritis, but you still have, no, you can have skin problems, but it is a form of arthritis. Guys, today we are learning so funny things, right? Imagine having a skin problem and you don't know it's a form of arthritis. Eh? So, a skin condition characterized by red, scaly plaques. Plaques are things like things that are, let me remove this first, put it somewhere here where someone can view it well. So, plaques are things like scales on your skin, and they are reddish. And they are reddish. Hmm? It belongs to a group, this psoriasis arthritis, seronegative spondyloarthropathies. These are not big words. Spondylitis, seroarthropathies are not big words. They just mean this type of arthritis does not come with your family line or genetic line being positive on rheumatoid factor that classify you as an arthritis person. You see, those words are just medical words, big medical words that mean very little. But when you understand them, you now know, you see, seronegative spondyloarthropathies means you have arthritis of the skin, but you are not rheumatoid factor positive. When I take your blood, take to the lab, it doesn't come out rheumatic factor positive. You see, even this one called ankylosing spondylitis that goes to the about spondylitis ankylosing of the back, you will see your rheumatic factor is not positive. You see it, and this one, the skin arthritis, which is psoriatic arthritis, affects joints, ethers, where tendon ligaments insert to the bone. Now I have to draw where tendon ligaments insert to the bone. Let me draw so that we understand. Look here, your here is okay. Your leg, I'll draw the femur. The femur is here. And then this is your thigh. This is your thigh. The leg has come like this. This is your leg, your leg, your leg has come. Now, here we are talking about the leg at the, you see, now down here we have the two bones. The two bones, this is the femur, and this one is tibia and fibula. The two bones, tibia and fibula. So alongside this, there are some tendons. The tendons are linked. So here we have a bone, a small bone on your knee, this small bone called the patella. The patella. Now, the patella is what you touch when you touch your knee. You get it? But now, how does this affect your bones? How does the skin arthritis affect your bone? Let's look here. How the skin arthritis affects the bone. Psoriatic arthritis is an inflammatory autoimmune arthritis that occurs in some people with psoriasis, a skin condition characterized by red scaly. It belongs to those that are negative on rheumatic factor, but it affects the joint ethers where tendon ligaments insert to bone. So there are some things called the tendons. The tendons are this one. You see, the red ones are the tendons. These tendons, where they insert to bone, where they touch your bones here, where they touch your bones, that is where it affects. The epith, where this tendon that is attaching to a bone that is causing the leavage. Let me take another, this one. We have another tendon in your leg. This is your leg. This one is the knee. This one is the knee. But here we have your leg. Your leg has a bone inside called calcaneus. This one is called calcaneus. So if this is the calcaneus and you have psoriatic and arthritis of the skin, where will it affect? The tendon. Here we have the tendon. So it affects where this tendon is touching the calcaneus. You see, it is not affecting the bone. It is affecting where this tendon, the red tendon, is attaching to the bone. Here. You understand? You understand? We check this again. This tendon of the patella, it attaches here. So it affects there. So let's continue. Let's continue. Let's continue. So if it is affecting where the tendon is attaching to the bone, what do you think will happen? You will have a bone that is, a leg that is hanging, because these tendons are the ones which are holding your leg. These tendons are the ones which are holding your leg. You get it? Let me move it closer. Psoriatic arthritis affects where the tendon touches. This is the calcaneus of your leg. But we have this tendon which is attaching to these bones. So it will attach here, it will affect here, and this tendon will be loose. So what will happen to your leg? It will always be, someone will be walking while it is brushing down, because this one is not pushing it where it is supposed to be pushed. Same as the other one, which is your thigh bone, your thigh, the patella, the tibia. Now we continue with this program of ours today. When we talk about psoriatic arthritis, it affects the joint ethers. So causes, what are the causes? Imagine you are having skin problem and thinking you have the skin problem, but in the other way, it is arthritis. And we have said psoriatic arthritis affects the ethers of the bone. Ethers of the bone is where a tendon attaches to the, and you know what is a tendon? A tendon is a rubber thing, a white rubber thing that holds bones together. It is a tough rubber thing that holds bone together, so that, like this one, the calcaneus bone on your leg, your leg cannot stay. Like if you don't have this tendon, your leg will be like this, So this one, like this, your leg will be like that. But this is a form of arthritis that goes to your leg and destroys the tendon ethers, where the tendon is attached to the bone, because it is coming from your skin and going inside your blood, and then it goes to the ethers of your bone. Ethers of your bone is where a tendon attaches to the bone. And tendons, their job is to fix your leg or your arm or somewhere. Yes, Michael N., big up always. Today we are talking about skin diseases that people didn't know this is a form of arthritis. You get it? Now, what can cause this? Mostly, it is genetic. And there's something that I've always said, HLA alleles. Those are genetic factors that makes people prone to psoriasis, skin problem. Just know HLA factors. Doctors in the house know deeper than that. And then we have immunity mechanism, overreaction of T helper cells. In your immune system, let's say when you eat something, when you eat something and then it reacts. What reacts is this? There are some cells in your body that awaken, and they say this person has eaten, but there is a strange thing that is not supposed to be here. So the T cells, they multiply and they awaken other cells called the neutrophils. The neutrophils, they are the soldiers to fight in the war. So when they are awakened, they start multiplying, and the soldiers die in war. So when soldiers die in war, they let me say, some others come in. So these cells are called the T cells that multiply so faster. And when they multiply so faster, what happens? It becomes a form of arthritis because you have a lot of these cells that are killing your tendons, right from your skin that is allergic to something and forming the skin problem, right to the essence of your tendons that are weak. So a lot of T helpers that are awakened by like dust, perfumes, something bad odor. There are some people, when they hear about bad odor, they awaken these cells so much. When the T cells become so many in your system, what happens? The essence of your bone are destroyed, the tendons. So what do people do? You stay away from some things that, if you are hyperreactive to some things, and you will see some people that are very allergic to some things and they have skin problems, you will notice that some of their bones are so weak. If you notice someone has skin issues that don't go away, skin patches that are scaly and red, and he is always overreactive on some perfumes, some things, check on the bones. You will see this person sometimes has no power of the bones. Why? Because it's not that this person does not have muscles. This person has muscles. But the problem is the attachment of the tendons, the ethers. Ethers is where a tendon attaches to the bone, is weak. It has been eaten by T helper cell. You check it. So your immunity itself can be a problem to you, because if you are hyperreactive to some things, it can bring you to have these problems. And then we have environmental triggers, physical trauma, injury, and then it causes psoriasis, infection of the skin. You know, when you as a person, you are not, even if you go to wash yourself, you are not 100% sterile. There is something called Streptococcus aureus on your skin that is always helping you to kill other bad germs that may enter your. It is a form of immunity. We live symbiotically with them. But when they come so high in your system, what happens? They start hurting you. You get it? So, infections, streptococcal throat infection. You get sore throats and they get into your system. And then what do? Some people, when they get sore throats, they become so weak because streptococcus eats the ethers of the bone, ethers of the tendon, so that a person is so weak. When you treat this person, after some time, he's okay. You get it? And then we talk always of stress and worsening obesity. This can worsen the situation. So when you are becoming big and you can't climb stairs, just know there is a problem that is going on, and you should check out on that problem. And that problem is psoriatic arthritis. If you are weak, you have weak bones, hypersensitivity on the airway, and your skin is always rashy, you have scales that are red, just know you should see a dermatologist, or you should see your doctor to advise. You get it? Now, how does this happen? Because we have talked about psoriatic skin problem that causes arthritis. How does this happen? You see, hyperproliferation of keratinocytes. Keratinocytes are cells of your skin. Thick psoriatic, it brings problems because it brings skin plaques, rashes like, red rashes like. A person who is hypersensitivity has these keratinoids that are so many in the skin that are bringing these problems. We understand ourselves? Yes. And then immune-mediated inflammation, synovial and ethers. Ethers, we are still talking the ethers. And I've said ethers is where the bone is attached to the tendon. You see, when you are hyperreactive and your skin, you are always scratching yourself, the cells of your skin multiply so fast to form a thick layer to protect you. But remember, you still have the problem of T helper cell, which is multiplying so fast. So what does it do? It destroys your tendon that is attaching to your bone. This is a form of arthritis. So you will be going to a pharmacy over the counter, you take cetirizine or Piriton because you think this is just a normal thing that is happening to you, which is an hypersensitivity reaction. You are allergic, but you really don't know you have a form of arthritis that is killing your tendons. You get it? Some things, when you see them recurring, you are always allergic and having some skin problems. Please, always consult. Don't always say, this is just something that I can go take a Piriton and then I'm okay. You see, so infection of the throat, we have talked about it. Now we are going to how it affects. Now the ethers formation, and it, when ethers are destroyed, remember where the ethers is attached, there is a cartilage. So the cartilage is destroyed again. But this one is not like unlike rheumatic arthritis, whereby in rheumatic arthritis can be both, you see, erosion and new bone formation. In rheumatic arthritis, when the bone is eroded, a new bone is formed. Here we are dealing with the tendons. When your tendon is destroyed, it is not formed. We need to find a way to fix it. You get it? New bone formation, like in ankylosing spondylitis of the back. We are talking about it just right now. So this one is an alarm. Ring a bell on yourself. If you've been having a reaction on your skin and you've started forming scaly, like thick layers of your skin, always scratching yourself, and then you are starting to feel so weak, even carrying your leg up is a problem, just know it's a form of arthritis. Visit your physician, let your physician do something on you, because if you don't visit, tendon cannot be repaired easily. If this arthritis eats your tendon, you will be immobile. Your bones will be okay, but the tendons destroyed and the cartilages moving is a problem. Unlike the other form of arthritis, rheumatic arthritis, whereby the bone is eaten but it still grows. Now, that is how things are. How does it, how does it, how can you see, how can you look at a person and then you say, this one is psoriatic arthritis. But we have said, when I'm talking about psoriatic arthritis, see, look at psoriasis, skin problem. The main features are psoriasis, skin problem with rashes that are big, scaly, red. And then hypersensitivity, like a person who has asthma. The third one, body malaise, body weakness and joint problems and weaknesses. Look at that and see. You look at the 5 main patterns of this. Symmetric polyarthritis resembles rheumatoid arthritis, but it is negative on rheumatoid. You don't have rheumatoid arthritis, but your small joints and the hands are destroyed. You see, small joints of the hands and even the legs are destroyed. And then asymmetry oligoarthritis involves few joints, often large joints, one side of the body. Oligoarthritis. So we say polyarthritis, small joints, because the small joints have tendons. But when it comes to large joints like the humerus. The humerus is this bone, this one, and the other one, the femur here, and then we have the other one, which is the fibula and tibia. You get it? It is affected in one side, not both. Here in these are the 5 features that I'm saying. You look at a person is hypersensitive, the skin is rashy and scaly and dry with red patches. The first we have said, you don't have rheumatic factor positive when you go to the lab to be assessed, when your blood is taken, but the small joints of your fingers have a problem. They look like this or like this, or at times you cannot do this. The second one is asymmetry oligoarthritis. One bone is affected, the long bones that I've said, humerus, the foot, femur, or the tibia or fibula. You see those ones. And then we have the other one, the third one, distal joint arthritis. Distal is away. Predominantly affects DIP joints of the fingers, toes, often associated with nail changes. Distal is away from here. So when you hear about distal, you know it affects here, and then it destroys your nail. Look at a person, look at the skin. It is scaly and has red patches. Look at the fingers. Are they symmetrically destroyed? Look at that person, one side. Is one of the long bones affected? You get it? And then we have arthritis, mutilans, severe destructive form, shortness, deformed fingers. Your fingers are short because the tendons are cut, so it is being pushed on one side. So if a tendon, like if this tendon, let me say, it's like a rubber band. If this tendon breaks down here, this leg will go down. You see, if this tendon of the patella breaks down here, the patella will be pushed up. Most of the tendons are like rubber bands. So spondylitis is inflammation of the spine, sacral joint, morning stiffness, and back issues. So we are talking about the main things, the 5 main things when you look at a person and you see, and you say, this is psoriatic arthritis, symmetry polyarthritis, asymmetric oligoarthritis, one long bone, distal phalanges that are destroyed, arrhythmia, mutilans, shortness of the fingers, and then spondylitis, back problems. Other signs may be dactyly, sausage digits that are swollen and round, sausage-like. And then ethsis, pain in tendons. Where tendons are, there is pain because they are being eaten. Nail changes. Sometimes our nails they look like destroyed. Skin psoriasis. That one I've talked about every time. Look at a person, the skin is destroyed and he is always hypersensitive. And then extra-articular features. Your eyes have a problem. Your eyes, you see, they are always crying, associated with inflammatory bowel disease. Stomach, you diarrhea every time, no food stays in your stomach. And then you have an increased risk of cholesterol deposits in your body. So you go to a hospital, you are told, let's get your blood, we want to look at your cholesterol, and you have arthritis. Don't be mad at the doctor. No, just know he's finding out if you have psoriasis arthritis. Let's ask those questions as we continue. And we see. The best things with these videos of medical talk, when you see something away, you can go back to this video and my tennis guy is in the building. Welcome, my tennis guy. We are talking about arthritis. But if you have someone who has undergone these things, please give us the situation. Let's see how you managed it. So how do you see that? How do you treat or let's classify first. Classification criteria of psoriatic arthritis. Evidence of psoriasis, we have said, is a must. Arthritis of the skin and the tendons. It's a must you have the skin problem of your itchy, redness, and it is dry scaly patches. You must have. Nail dystrophy. Your nails should be destroyed a bit. And then negative rheumatic factor. I've said rheumatic factor is when you are taking blood to the lab and then it turns out reactive. In psoriasis, it should not be reactive. You get it? Ductility, current history of ductility, the sausage like finger type, you remember them? Ductility, sausage like finger, like they are round. You have fingers that are swollen and round. You should have that. And then we have radiographic juxtaarterial newborn formation. When you go and do an X-ray, you will see it's like some bones are being formed. So 3 of these or above, or the 5 of them, qualifies that person to be called psoriatic arthritis patient. If you have like evidence of skin problems, your rheumatic factor negative, and your nails are destroyed, and you look like you have finger like sausages, you have this arthritis of the skin. It should be treated like arthritis of the skin, which is called psoriatic arthritis. You get it? We don't just have arthritis of the bones alone. Now we know we have arthritis of the skin that affects the tendons, but when you go to the lab to check, it will turn negative. You get it? This one, you can confuse it with rheumatic arthritis, osteoarthritis, reactive arthritis like the infectious arthritis, and ankylosing spondylitis, the one that we are going to speak to next, and gout or pseudoarthritis. They can be confused because if you look at the person, he has gout arthritis, but you remember with gout we said the long toe starts to be affected. You remember us talking about this toe? Gout arthritis. Now, we continue. Today, questions are not coming in. People are keenly listening. Let's ask a question. Management, how do you manage this? Reduce the pain. Reduce them by NSAIDs, but you be cautious of NSAIDs. NSAIDs are drugs like Brufen, aceclofenac, diclofenac. Be cautious when using them when you have pain, because they will increase your acidity, and you are having pain. Your pain will go down for some time, then it will come back. So if you are a person who has acidity issues and ulceration, don't use NSAIDs. Use drugs like mefenamic. Use drugs like Cox B. You use paracetamol. Yes, you see, meloxicam, those ones, they reduce pain so good, but don't rely on NSAIDs. Yes, we continue. Prevent joint damage. Always take care of your joints. Don't do exercises that are of kneeling, squatting, always working while squatting. Prevent the joints. Improve functions and quality of life. Always eat food that can repair your joints and your body, like foods that are rich in vitamin D. You get it? Reduce the pain and inflammation. Inflammation, use drugs like prednisolone, those ones. Yeah. You always teach people, educate people about this, because this is the kind of arthritis that people don't know. And then physical and occupational therapy, weight management, and then we stop smoking. Smoking, I said, smoking brings something called free radicals, and free radicals is a problem to the body when it comes to cancer. Yeah. Okay, so drugs, we have talked about NSAIDs, and then there is a drug called diamide, disease modifying anti-rheumatic drugs. Everyone, if you have ever seen someone who is on arthritis, a doctor has written something called methotrexate. Methotrexate helps to reduce the inflammation and helps to modify you not to get to advanced diseases. Sulfasalazine. So those are disease modifying agents, biological agents, diamides like TNF, tumor necrotic factor, adalimumab. When there was COVID, there were some drugs that were being that were very specific. It's only written by a consultant or a physician who is chosen. Those were called biological agents like adalimumab. Those ones, you remember? The COVID struck people so hard. Yes. Target synthesis diamides, apremilast, those ones help. They help a patient not to go to the next stage. These are for advanced. And then remember, because you are hypersensitive and you need something to help you, you need to have skin management like topical steroids like betamethasone to apply on the skin and vitamin D analogs. You remember what we talked about vitamin D? Vitamin D is a cofactor of, you remember, very important, of calcium. Phototherapy, systemic agents like methotrexate, biologics. Very good, very nice, and very cool. Today, at least you have known there is a arthritis that is of the skin but affects the bone. You imagine arthritis of the skin but affects the bone. Very funny, eh? Yes. Now, if there is arthritis of the skin and affects the bone, we have talked about this. We are still talking about inflammatory arthritis. It was rheumatoid arthritis. Now we have psoriatic arthritis. We talked about rheumatoid arthritis. Now we have talked about psoriatic arthritis. But we have another form of arthritis called the juvenile arthritis. So, juvenile arthritis, what do you understand about juvenile? Every person, when you hear about a juvenile, you know a juvenile is a kid, a young kid. Juvenile arthritis, what do we know? Somebody may ask, like, this is a young child. How can a young child be born with arthritis? Then you start wondering, wondering. Janet Osborne. Janet Osborne is in the platform. We thank you coming, joining. Hope you are watching from Jamaica. Enough love, enough love from Kenya too. We are continuing in our topic, Janet Osborne. We are talking about juvenile arthritis. You have just talked about psoriatic arthritis, arthritis that affects your skin. Let the question come. Let those people that have experiences on these issues come. Let's challenge and help each other, please. Don't just watch. Ask a question. A friend might be here that might help you, or even a drug that maybe it helped so much. Now, juvenile arthritis is a group of chronic autoimmune arthritis that begin before the age of 16. You see, juvenile kids before the age of 16 persists for like 6 weeks and has no other identifiable cause. It is not psoriatic. You are not rheumatoid factor positive, but it is just presenting. It is most common chronic rheumatic disease in children. You get it? Idiopathic means exact cause is not known. You see, now it has affected so many children around the globe. Sometimes you may be in your office and then you find a parent coming in with a kid who is not walking well. Then you ask, have you fallen down? A kid just told you, no, I just woke up when my feet is swollen around the knee. The first thing you think of is arthritis. A swollen feet without any trauma, you think of arthritis. You get it? So we link this to genetics. There are some genetical factors like the HLA that I usually talk about. They are linked to this factor, genetic factor. And at times, when you have an HLA factor of polyarticular rheumatic factor positive, You see, when you have these factors, what happens? What happens is this. When you get an infection as a kid, we have said it's below 16 years. When your kid gets an infection like parovirus, P19 or EBV virus, is infected by that virus or a flu virus, it's whereby you see this child behaves with, is very having fever, high fever. This child is very feverish, but his knees or her knees are swollen. Or this child was just playing football and someone hit, not so hard, but tomorrow in the morning can't wake up. Or this child is undergoing some stress and the knees are swelling. You get it? Eh? Some possible exposure to a person who has flu. You get it? It's very funny how this comes in. Then you start wondering, why is my kid having high fever and swollen the feet? I've seen some uh, parents in Kenya saying that my kid has has malaria. That's why it comes like that. I don't know why people associate malaria with fever a lot. Hmm? So when you are exposed to these things that I've said, there is something called autoimmune activation. The T cells, I'm still talking about the T cells, like in psoriatic arthritis. The T cells are excited and they bring something called tumor necrotic factor alpha. Eh? It comes in because now it wants to kill the stranger that is in on a body. Hmm? And then remember, around the synovial fluid, around your knees, the cushion that we talked about, the cartilage is destroyed by the TNF alpha because it is sensing like the cartilage is a stranger to your body, and this is a child. You see, an associated factor of rheumatic factor ends up to eat the bones of your cartilage as a child. And you see, this is the child who is growing. So it may affect the plates of growth. So most of this child may remain short. The growth plates are affected. The limb length, one of the limb is shorter than the other. And then the growth factor is down because this child is affected where the growth plates are. Hmm? You see how it happens? Hmm? So we still have the factors that we have in psoriatic arthritis like oligoarticular, large joints, usually large joints of the knee, ankle, and elbow, because as you react, the bones become big and hard. Polyarticular, you see, some 2 or 3 joints are affected in the beginning of life, like the first, second year, third year. But before this child reaches 16 years, most of the joints are affected. So when you do rheumatic factor of this child, you will find that this child is a rheumatic factor positive, a child with arthritis, because this child was born with a genetic factor HLA factor of arthritis. Arthritis daily spiking, salmon pink Everest rash. We will see this child, if he's a bright child with a skin that is bright, there is a pink salmon patch somewhere, a child waking up, sometimes the in the face somewhere here there is a pink patch, salmon. Then you wonder, what did this child do at night? A thesis-related arthritis, inflammation of the tendons, insertion, thesis, and thesis, where the tendon inflammation, sometimes when those tendons swell, you cannot walk. And sometimes it's related to polyarthritis. Maybe you will see you have a child who has skin problems, and then it excites these problems. When the skin starts to have a rash, walking becomes a problem, movement becomes a problem. But remember, the main age limit should be below 16. So this is a child who is producing all these symptoms. Eh? Arthritis, psoriasis, or arthritis of the ductility are the hands that look like sausages, hands like that look like sausages, nails that are pitting, they are destroyed. A child is so young, but you see the nails are being destroyed, and some family history of hypersensitivity and rashes in the body. You see, so in this child, you will see joint pain, swelling, stiffness, limping, reduced range of motion, and at times warm but not usually very red joints. This child is just having fever, but the joints that are swollen are not red. You get it? And the eyes, chronic anterior uveitis. Uveitis, we talk about eyes that are removing some tears, like he is exposed to some smoke. You get it? May cause blindness if undetected. You see, uveitis is an eye condition. Uveitis. These eye conditions is uveitis is an eye condition that can cause blindness. Uvea is inflammation of the uvea of the eye, the middle layer of the eye, which is consists of the middle layer of the eye consists of iris, cilia body, and choroid body. So when it swells, you look at the eye and you see some blue eye. This child had no eyes that were blue, but right now you are seeing some blue eyes that are swollen. You know that is uveitis. So you know your child has a problem of arthritis, but you have those other symptoms, skin, and then swollen limbs. You see, the skin having psoriasis, at times fever, fatigue, malaise, and weight loss, and sometimes limping. You see, and the limb sometimes is short than the other. In children, this is a difficult situation because it may cause growth disturbance due to inflammation or corticosteroids, because this child will be always on steroids to reduce inflammation, and you see this can reduce growth. Joint contractures, joints that cannot move well, joints that are stiff because of the tendons and the cartilages that are destroyed and they are forming like bones. Because now we have seen it has gone up to the eye, the inflammation of the uvea. You get it? The uvea, we have said, the uvea is categorized into iris, the three. You get it? A minute. Logo to symptoms, prognosis. Yes, we have said the uvea is the iris and the layer that is surrounding it. You see, so this child may be blind, and then you start wondering what is happening. So it is very important to be looking at your child, and some things don't ignore. The bones of the child may have osteoporosis. They are just destroying themselves and eating themselves. You see, so when you take this child to a hospital, they'll do some tests like the ferritin to check if the blood, hemoglobin, and the others are okay. They'll do rheumatic factor to find out if you have that genetic LHLA factor. Often, you see, ESR for inflammation in the lab, blood count in the blood, and then they'll do X-rays to find out if the joints are destroyed, MRI to detect synovial and cartilage damage earlier so that they can stop it. And management of this is just like the psoriasis, because you control inflammation, prevent damage by diamides, methotrexate, disease modifying agents. You get it? And prevent uveitis complications of the eye. You may require to see an ophthalmologist if you see your child has been okay, but when you look at the eyes, they look blue and big. The round dark thing looks blue. You may need to take your child to an ophthalmologist to know what drug to give. And articular injections for flares. Sometimes you give corticosteroids to reduce the inflammation. You see now, the disease of the children, juvenile arthritis, is so complicated. So don't ignore some signs in children thinking that it's normal. Recurrent skin rash, waking up in the morning while this child cannot come out of bed, and you start saying my child doesn't want to go to school. And you look at the knees, they are swollen, but they are not red. You see, those are signs of juvenile arthritis. And juvenile arthritis can be treated. It can be managed, and this child may live well. So any question on juvenile arthritis as we go, we see the other forms of arthritis. We are left with ankylosing spondylitis. Ankylosing spondylitis. Ankylosing spondylitis, that one I'll do it in 10 minutes because our time is getting out of hand. Now, juvenile arthritis, you have seen, is disease of the children, and it may present as disease of psoriasis arthritis, this arthritis of the skin. So when we are talking about spondylitis ankylosing, we are talking about the disease of, wait a minute, spondylitis arthritis affects the bones of your back. You see, so when we're talking about these are diseases that affect your back, the cartilage of your back. Here in that, where is this paper now? The axial skeleton. The axial skeleton. The axial skeleton. Let me see. This one can hang here. Yes. The axial skeleton. The axial skeleton is the sacroiliac joints. These are joints of your back. These are joints of your back. These are joints of your back here. And then we have this one, this one. Now I've drawn a figure there that represents something. So ankylosing spondylitis is a chronic progressive inflammation that primarily affects the axial skeleton. We have in your body, we have two types of skeletons. We have the appendicular skeleton, and then we have the appendicular skeleton and the axial skeleton. So the axial skeleton is this one, the straight one, the backbone. You get it? The affects the spine and the sacroiliac joint here. Sacroiliac joint, leading to pain, stiffness, eventually erosion of the vertebra. What I've drawn here, these are the bones that are called the vertebrae. This one is the clavicle. This one is the clavicle bone, and this one is the femur. That is the femur, but we have the chest here, the chest that has the bones of the chest here. See, so we continue. It belongs to a group of seronegative. It is not positive on arthritis. You get it? But it's strong associated. It's LA. That thing, genetic factor called the LA factor, is strongly related to this. You see, so inflammation occurs of the edges. Edges, where ligaments, tendons attach to bone, especially spine, sacroiliac joints. So the edges, we have the red things that I'm drawing here, and then we have the ligaments here. The ligaments, the ligaments, the ligaments, the ligaments. So ethers is where the tendons attach to a bone. So if the ethers are attaching to a bone, where does it attach? Here. You see, so if it is affected, your bone will bend, or it will go, or it will form an S. Instead of it being straight, it will form an S or a curve like this. Your back will be like that. You see, pathophysiology is whereby the inflammation of the ethers, chronic inflammation of the bone. So when these ethers are destroyed, this bone of the back touches the other one, and then they start to erode. Some repair, but it's still going on, still going on. New bone formation is formed and it is still being eroded. You see, now you will always have chronic back pains, morning stiffness, sacroiliitis, buttock pain because there are some muscles that are attached to the buttock from here, muscles here from the back. But we have seen the attachment is where it is. So the muscle that is attached to the back, what will it happen to it? It will be eaten, and the excess will be eaten where it is attached. Sorry. You see, it will be eaten at the apex, and every time you want to move, you feel pain. Even if you want to sleep, because the muscles cannot help, they have to contract and relax. You feel pain. You get it? So it will always have chronic back pain, morning stiffness, sacroiliac, buttock pain, buttock from the muscle of the buttocks. Alternative sides. If it is paining this side, the other time it will pain this side. Reduce spinal mobility. And you see, if your spinal is not shaped, your normal spine should be shaped as an S that is looking like this. But now, when it looks like this, a C shape, that is a problem. So you will have a back that is like this. You see, peripheral arthritis, extra-articular. You see, uveitis, your eyes are affected. Still the eyes, we are talking about the eyes. Cardiac, aortic regurgitation, problems with the heart. I'll talk about aortic regurgitation. You'll have problem with the heart. Complication is spinal fracture, because these bones are attached are not okay. You'll get a fracture due to osteoporosis. Your bones are being eaten. Severe kyphosis. Kyphosis posture is like this. You are bent like this in front. Reduced lung expansion. The lungs, because the tendons are pressuring them inside, you have reduced lung expansion. You see? And then you go to the lab, you do something called rheumatic factor, it's negative. ESR, inflammation is high because CRP measures the inflammation rate in your body. HLA B27 is the defining one. It is positive here in this back problem, ankylosing spondylitis. The other things that you may do is like an X-ray, an MRI to check how the damage is, and then we know how to manage it. Yeah? So the goals here of management of this is to relieve pain, maintain posture of the spinal, not to be destroyed more, prevent complications like spinal fracture. If your spine is fractured, you will not walk, my friend. You will always be have paralysis. And then exercise, avoid prolonged rest down when you are seated, because now you are killing your tendons more. You get it? Use NSAIDs a bit, diamides like methotrexate, they'll help. Corticosteroids, Be careful about them when you use them. We don't want you have a problem with the back, although they are reducing pain, and then you have sugars that are rising. No, you see. Now that is about ankylosing spondylitis. You see, most of these things they they relate. They share some things and some things they don't share. So when we talk about types of arthritis, we have talked about types of arthritis that have inflammation. That the other type that we have not talked about, that is not that we have talked about, that is not inflammatory, is osteoarthritis. That one lies in its own. It is called degenerative arthritis because it wears the bones off. But inflammatory is inflammation, swelling. So the inflammatory ones, we have covered them. And then we did one which is gout arthritis, which is metabolic arthritis. So tomorrow we will do one that is left, which is pseudo gout. We did gout, but we will finish tomorrow with pseudo gout. Inflammatory arthritis, we have dealt with it. We have done rheumatic arthritis, psoriatic arthritis, ankylosing spondylitis, juvenile idiopathic arthritis for kids under 16, reactive arthritis triggered by infection, and then we have done infectious arthritis. Though, so tomorrow we will do pseudo gout, and then we will come and do arthritis related to other conditions like systemic lupus erythematosus, sarcoid arthritis, enteropathic arthritis, and hemarthrosis related arthritis. Those ones are, we will cover them tomorrow, and we finish arthritis. Then we go to the last one, which will be mental assessment of arthritis, arthritis related mental health problems. So that is where we are before we go and learn how the kidney works. Before we go and learn how the kidney works. So for today, I think it is here, it is 7, and I only had 1.5 hours, and I think 1 hour. I had 1 hour today. I think it is important we reach there. I'll give some time for any question. Any question, if a person has any question to ask. Even if it is not on arthritis, any question that is not on arthritis, it will be okay. Anyone who has a question as we finish, anyone who has a question. The good thing is you can go back when you have some time and something you did not understand, you check, you listen. If you still don't understand, you'll come back and ask me a question. I'm giving time for any person who has a question. Any person who has a question. Any person who has a question. Okay, I assume there is no question. Thank you so much for everyone who has been here. Let's meet tomorrow as we do the other remained arthritis. Be blessed always. See you tomorrow.